Welcome and thank you again for joining us for our interview with the Doctor series. Today we have with us Dr. James Pacey with Orland and Cohn. Dr. Pacey, thanks again for joining us and giving us some of your time. If you could just give us a brief description and a little bit about yourself, and then we'll get started in talking about UCL elbow injuries.
Sure. Thanks, Carrie. Thanks for having me today. It's a great option to get some information out to everybody. So my name is James Pacey. I am an orthopedic sports medicine specialist at the Orland and Cohn Orthopedic Group. I am the director of sports medicine and orthopedics for Suffolk County for the group. I'm also the team physician for Long Island University, for Farmingdale State College, and for multiple high schools around the county, and also the head team physician for the New York Riptide professional lacrosse team, and a consultant for the Premier Lacrosse League. My practice is based mostly out of Suffolk County. I see patients in Smithtown as well as in our Woodbury office. I've been practicing in Suffolk County for over 10 years now. My practice basically is sports medicine. I do shoulder, elbow, and knee surgery and treat general sports medicine conditions.
Excellent. Thank you. Thank you for that info. So today we're going to talk about UCL or ulnar collateral ligament injuries in the elbow. So if Dr. Pacey, you could start just telling us what are some of the causes or possible risk factors that could put a student athlete or even just a member of the general population at risk to injure this particular ligament?
So UCL injuries in general, obviously baseball players are the biggest population, but we also see them traumatically in wrestlers and lacrosse players. We also see them in gymnasts, cheerleaders, people who walk on their hands. And in that case, it's more like a knee medial collateral ligament injury, whereas in baseball, it tends to be more of an overuse type situation, or can be a single pitch pop that we see at times. Most of the time in the baseball population, again, it's an overuse kind of thing. It's sort of, we like to say it reaches the odometer limit on the elbow and the ligament tends to fail. Usually these injuries are progressive. People have gradual pain over time and then get to a point where they're unable to perform. Although we do see these in work-related situations as well. I recently saw a sanitation worker who was throwing a heavy garbage can and reached back to pull it up into the truck and tore his UCL. So really can happen in many different situations, but in the sports world, we tend to focus on the baseball athlete, the gymnast, the cheerleader, occasional football player, things along those lines.
Interesting. Who'd have thought a garbage man would do it? Crazy.
Yeah, listen, you never know what's going to walk into your office, right?
Fair enough. Fair enough.
This particular garbage man also happens to be a professional boxer, so he's actually going to wind up needing to get fixed.
Interesting. Now, what are some of you said he's going to need to end up getting fixed as a professional boxer. What are some of the treatment options for this particular injury, and how do you determine which treatment option is going to be the best route?
So really for UCL tears, there's non-operative management, there's sort of biologic intervention, and then there's surgical management. Generally speaking, with younger athletes, we try and do more conservative treatment. And in partial tears and things along those lines, we lean towards more conservative treatment. In complete tears and higher level athletes, surgical management may be warranted. And certainly surgery may be warranted in the younger athlete as well. For non-operative management, generally speaking, we focus on their mechanics, their biomechanics really. So most of these kids and pros will have deficits in range of motion in their shoulder, range of motion in their hips. There's something else that's leading to the increased strain on the elbow to cause the UCL to go. So we treat them potentially with a brace and an acute injury, especially a traumatic injury, try and rehab them, work on their shoulder range of motion, work on their hip range of motion, core strength, lower extremity strength, back stability, core stability, and see how they do. If we can get their pain to a tolerable level or below, if we can get their mechanics back so their internal rotation and total arc of motion of their shoulder is normalized and their pain is gone, we'll bring them through a throwing program and try and get them back. The biologic treatment option that's most commonly used would be PRP, platelet-rich plasma injections. The PRP injections work very well for partial tears. They tend to work better for proximal tears up on the humeral side as opposed to distal tears on the ulnar side, because the proximal portion of the ligament has a better blood supply, tends to do better with non-operative management than the distal tears. The distal tears, the ligament tends to peel off of the bone. Once it peels off of the bone, the joint fluid actually gets underneath that distal ligament. Joint fluid has properties that allow our joints to move properly. And what it does is it limits scarring, right? So the ability for that ligament to heal down distally without surgery is a lot more difficult, because that joint fluid kind of slides in underneath where the tear is. Although we will try non-operative management for smaller tears there, we tend to let patients know that there's a lower chance of getting better with non-operative care there. So should a patient fail non-operative care or go through a non-operative treatment pathway, try and get back through a throwing program and continue to have pain and inability to perform, then we move to a operative situation. So in terms of operative management for the UCL, there are two main procedures at this point. There's UCL repair, which is a newer technique, or UCL reconstruction. So the difference there is between repairing the native tissue, the patient's own tissue, without taking a graft from somewhere else, or reconstructing using a graft. So the traditional Tommy John procedure is a tendon graft transfer. So you're either taking the palmaris longus graft out of the same arm or a hamstring tendon out of the leg. Some people are even using allograft tissue at this point. The idea there is that you're adding collagen back to the deficient ligament. And there are certainly indications for that. Somebody that has a complete tear through the mid portion of the ligament, somebody that has significant degeneration of the ligament would need a reconstruction, certainly.
So what would be some things that would cause, obviously a complete tear would be potentially acute, or if the overuse is so long, but what would potentially cause like the disruption that you were talking about?
So, that's sort of the single pop moment. Okay. And on an MRI, we can determine which side of the ligament is torn. Is the proximal side, is it the distal side, or is it tear right down the middle? It's extremely rare to see a rupture right through the middle of the tendon, although they do happen. I had a few of them recently, actually, that needed to be reconstructed because of that, and in young kids. It's just a matter of where they rupture. You can't repair a ligament side by side in the mid-substance. So in that situation, it needs to be reconstructed. Generally speaking, older patients with Tommy John injuries, because they've had so much wear and tear over time, and especially in the professional population, they just tend to have worse tissue there because it's just been beat up so much over the years, and they tend to lean towards reconstruction in that situation. However, if it's an avulsion tear off of one end or the other, it tears off that proximal side or it tears off the distal side, a repair is a terrific option. The repair incorporates something called an internal brace. Now, an internal brace is a really modern sports medicine concept that we use all over the body. And what we do is we support the ligamentous healing with a strap of suture material and anchors on the end. And we use the anchors also to tie the ligament back where it belongs. So we can retension the ligament to its proper tension. And then we lay this internal brace over the top to support it while it heals. And it's like rebar for the ligament.
Okay.
And biomechanically, the repair actually stands up better against a native ligament with biomechanical testing than reconstructions do. So it normalizes the native state better than a reconstruction does. The other benefit of the repair is we're able to get people back to play and back to work faster.
That was going to be my next question. What's the difference in return to function or return to activity, or, in the case of a student athlete, return to play in the repair versus the reconstruction?
So traditionally, the reconstruction timeline earliest is 9 months for a pitcher. I'll use pitcher as the standard, right? Mm-hmm. So it's usually 9 to 12 months, sometimes out to even 18 months to get a pitcher back full go from a reconstruction. And that's whether you're doing the modified Job Andrews technique that I perform, which is a figure of 8, or the docking technique. Really similar outcomes both sides. With a repair, we're able to get these kids back in 6 to 9 months almost routinely now. So it's really a much faster return to play process with the repair than the reconstruction. And what you see on the rehab side, generally speaking, with the reconstruction, when they start their throwing program, it tends to be sort of this jagged edge coming back. Good day, bad day, good day, bad day. And literally, they kind of oscillate their way back up the ladder because there's more tissue that needs to reincorporate and the body's got to do more work. For the repair, they tend to just sail right up the ladder. It's really amazing, the difference between the two.
Now, you mentioned that it is a newer technique in the sports medicine world. Has there been a lot of extensive long-term research or outcome information as far as, do they tend to break down faster as you go further and further from the repair? Does it tend to actually last longer, or is it still out to the jury?
So, we've been doing these for about 8 years at this point. They've held up very well overall. Jeff Dugas, who was one of my mentors down at Andrews, really has been the biggest proponent of this technique and was the first one to step up and really bring this to mainstream. He's probably got the biggest series that's been reported at this point. The return to play rates are right around 90 to 95%. I think he's had 2 failures that he's aware of, and one of them was from heterotopic bone formation. So very rare thing with any elbow surgery. That kid had his HO removed and is back throwing. There are several guys at the MLB level who have had repairs done at this point. And Jeff actually recently reported a pro athlete who had retorn a previous reconstruction that he went back and as a revision repaired. And that gentleman got back to playing baseball. So, it's certainly a paradigm shift in the treatment of the baseball athlete. The other spots where I really like the repair are in the gymnast or the cheerleader or the professional boxer. I have at least one professional boxer who's back fighting after a UCL repair with an internal brace. I think for those athletes, the repetitive stress isn't nearly as much as it is in the baseball athlete. It's really more that one-time bad punch, bad pivot on your elbow, doing a handspring or something along those lines. So I really like the idea of having the internal brace there as a backup when they're doing those types of activities. And we've had very good success with it.
That makes sense. That makes sense. So we talked about, what can we do if it happens? What can we do to potentially keep it from happening? Obviously, your gymnast, your boxer, some of those, or even your garbage man who has a one-time acute injury. That's obviously something that you can't necessarily always try to prevent. But what about for the overuse ones, your baseball players, your other overhead athletes? What can we do to try to prevent that overuse causation?
So that's really the holy grail, right? I mean, and we go out every day and we try and put ourselves out of business, so to speak. So there's a lot of things that we can do, a lot of things that we can monitor to this risk. So in terms of prevention, obviously everybody knows about pitch counts. This really started at the Little League level. Dr. Andrews was intimately involved, and Glenn Fleissig from ASMI were integral with working with Little League Baseball to implement pitch counts. The idea of pitch counts is to limit the stress on the growing arm. The problem is with pitch counts is they only count pitches during games, and they only count pitches in games with teams that play in leagues that have pitch counts, right? So if you have a kid who plays local ball with his Little League, school ball, and then has his travel team, and there's no communication between the 3 teams and their parents aren't keeping an eye on it, well, his pitch count limit's just tripled.
Right.
Right. So it's really about education. It's educating the parents, educating the athletes to the risk and why these things are in place. When when New York State recently put in the rules for the scholastic pitch count levels, I had to sit down and speak with all the coaches and the ADs in Suffolk County and explain why we're doing this, right? The kids actually were more comfortable with it because they were used to it from growing up playing Little League
Right.
than some of the administrators and coaches were. Now it's just part of the norm, right? This is what the expectation is. What else is important? Obviously, the prehab part of this is important. It's maintaining range of motion. It's adequate rest. It's adequate nutrition, right? The ligament itself, the UCL, has biomechanical properties such that every pitch that's thrown exceeds the strength of the ligament. So how does it stand up? How does it not tear every time you throw a baseball? Well, that's because the ligament's not really the one that's doing the work. It's the flexor pronator over the top of the ligament. So that muscle tendon structure really is what's holding on for dear life every time a pitch is thrown. However, once that fatigues, the stress goes on the ligament.
That makes
So
sense.
what the pitch counts really are about is trying to limit the fatigue on the muscle, which then limits the stress on the ligament and decreases the risk of the ligament tearing. So it's not about a strict number per se, although we use them because it's the best marker that we have. And it's very much estimated off of age, expected skeletal maturity, etc. It's really about fatigue. So how do we judge fatigue? There are a number of devices out there that are available to do this. One, for example, is the Modus sleeve. The Modus sleeve has an accelerometer that goes on the inside part of the elbow. It's got an app attached to it where you can track every ball that's thrown. Forget every pitch, bullpen sessions, warming up, long toss. It'll track everything for you. You just basically should glue these things to kids' elbows, and every time they throw, it tracks it, right? But what that does is it allows you to monitor fatigue because it sees the changes before the naked eye can, right? So it sees the biomechanical changes and goes, all right, he's throwing different now. She's throwing different now. Something's not right. It's time to back down. And I think as the technology advances, we're going to have a lot of weapons to fight in this war against the Tommy John injuries. But in reality, it's at this point, it's education. It's good programs to maintain range of motion. The number of kids that come into my office who have loss of total arc of motion, specifically early on, they lose internal rotation. You know, we expect them to gain external rotation and lose some internal rotation, but there's almost always a mismatch in the kids that come in with shoulder or elbow pain. So that's the first thing to address. Then their pitching mechanics, their throwing mechanics, and then it kind of snowballs from there. But really, it's volume and how hard you throw. So the harder you throw, the more risk you're at. And that's a double-edged sword, right? Because the kids that throw harder, that's your number one guy, right?
So
they're going to be
likely to throw more.
Exactly. They're going to be pushed to throw more. So that's the kid that you have to be extra careful with because they're still skeletally immature. They're throwing harder than everybody else. While their body's able to produce that kind of velocity, their muscles, their bones, their tendons, their ligaments may not be able to ready to handle that level of stress. I mean, the number of medial epicondyle avulsion fractures I've seen recently from skeletally immature kids literally popping the bone off instead of tearing the ligament has been crazy.
Wow. It's a big world out there. It seems very interesting though. It's cool to see how much technology is starting to play a role in the injury reduction rates and hopefully surgical reduction rates as well, not for you, but for your student athletes at least.
Yeah, 100%. I mean, you know, there's a lot that can be done up front, screening wise. You know, when I was at Stony Brook and now at LIU, we do range of motion testing quarterly on our baseball pitchers to make sure that they're not falling out of that ideal range side to side. If we see them start to lose total arc of motion beyond about 8 to 10 degrees, we tend to back them down and limit how much they're throwing to decrease the risk of shoulder and elbow injury. We were very successful with that at Stony Brook. We've been very successful at LIU with it. So there's definitely a lot that can be done if you're proactive about it, if you're engaged with the athletes, and if you get buy-in from the athletes.
Yeah. And it sounds like there's now not the career-ending story of, oh, you tore your UCL, you have to have Tommy John. It sounds like there are a lot of much better options at this point in order to get people back to the activity level that they want to be at, and safely.
Certainly. I mean, it's a double-edged sword, though, right? You hate to see kids have to have surgery, but it is terrific that we have such great treatment options at this point to allow the kids to get back to play and back doing what they enjoy, and give them opportunities to potentially play at the next level. For a high school kid to have an opportunity to get into a better college and university and get a better education than they could have without the opportunity to play sports. That's why we do this, and that's why I love what I do, and I'm blessed to have the career that I do.
Excellent. Well, thank you again, Dr. Pacey, so much for your time and all the wonderful knowledge and information. And we'll hopefully have you on again for another talk at some point.
Certainly, anytime. Thanks for doing this, Carrie, and thanks for everything you guys do at Ivy and the great job you do with and for my patients.
You got it. Have a wonderful day. Thanks.
You too.